Okay, so Chapter 6 is Periodontal Health, Gingival Diseases and Conditions. So in Chapter 4, I showed you a picture of the chart that the 2017 periodontal classifications, and on the far left was the Periodontal Health, Gingival Diseases and Conditions. In the middle was periodontitis, and on the far right were other factors for the periodontitis. And so we're going to start with, we're going to dissect each of those areas, but we're going to start with the periodontal health, gingival diseases, and conditions. So periodontal health is defined as a state free from inflammatory periodontal disease that allows an individual to function normally and avoid consequences, mental or physical, due to current or past disease. There's going to be an absence of bleeding and probing, erythema, edema, patient symptoms, attachment loss, and bone loss. So in periodontal health, you can have two different types of periodontal health. There's normal, and then there's a reduced periodontium, or normal we call intact. So an intact periodontium has no loss of periodontal tissue, past or present. So you look at the radiographs, this would be someone like each of you. You look at your teeth and your radiographs and your gingiva, and everything looks perfectly healthy. Your bone levels are where they should be. Your periodontal ligament fibers are intact. Your junctional epithelium is at the or above the CEJ. Everything is healthy. A reduced periodontium means that you have gingival health, but you had past current periodontal disease, or in other words, a pre-existing periodontal disease, but no current activity of loss of the connective tissue or of the alveolar bone. So this would be what we would consider or call a stable periodontitis patient, a patient that has had previous periodontal disease, but they've managed to keep it right where it is, or they've arrested it and it's staying right where it is. They're not continuing to show attachment loss. We do not use this category as much as we do having diagnosed them with just periodontitis. And the reason being is because it's really difficult to prove that there is no, that they have a history of no continuing attachment loss. Because periodontitis patients in general, you're going to find as we go through, as you become a hygienist, they tend to have areas that fluctuate a lot of times. So it might be a 3 millimeter or probing depth this time and a 4 next time. It might be a 4 this time, a 5, but then it goes back to a 4 or back to a 3, but it fluctuates. It's not just constantly stable. You will have some patients that never change, but they're not as common as the patient who has a little bit of fluctuation in their activity. So we have periodontal health on an intact periodontium. That's the patient that never had periodontal disease. We have periodontal health on a reduced periodontium in a non-periodontitis patient. I'm going to get to that category in a minute. Then we have the periodontal health on a reduced periodontium in a successfully treated stable periodontitis patient. This is the patient we just talked about that had a past history of periodontal disease, and now everything is stable and they are showing no signs of clinical attachment loss. The middle category, the periodontal health on a reduced periodontium in a non-periodontal patient, would be somebody that has gingival recession. So gingival recession is technically clinical attachment loss, but periodontitis is a loss or an infection. Remember, periodontitis is a bacterial infection. So if a patient brushes their teeth too hard and causes recession, or a patient wears orthodontic bands and they move the teeth too quickly and it causes recession on the lower incisors, which it can do, that is not considered periodontitis. Even though when you measure, you're going to have clinical attachment loss, that is not considered periodontitis because it wasn't lost due to a bacterial infection. Periodontitis, by definition, is a bacterial infection. So that would be considered a reduced periodontium because they've lost some clinical attachment, but they're a non-periodontal patient. This is a picture of periodontal health on an intact periodontium, and you can see the gingiva looks pink, firm, You can see some stippling. It has the nice arches. It's attached firmly to the teeth. It looks like it's got pointed or knife-like interdental papilla. So that patient tissue-wise looks good. And if you look at the radiograph next to it, you will see that the bone levels or the alveolar crest is just slightly below the CEJ where it should be. This is a picture of periodontal health on a reduced periodontium. So if you look at this patient, you can see the tissue looks pink, firm, stippled. They have knife-like interdental papilla in most places. However, the front teeth are not, the two central incisors are not in contact with each other, so the interdental papilla is flattened. But overall, that tissue looks really healthy. It's got the nice arches, but you can see they have gingival recession on 8 and 9. Well, they have it on other teeth too, but they only showed the radiograph of 8 and 9. So if you look at that gingival tissue, they have some loss, some attachment loss. But if you look at the radiograph, their radiographic bone height looks like it's still pretty much where it should be. It looks pretty intact. They have a slight bit of bone loss right between the two central incisors. But if you did those measurements, you're going to have clinical attachment loss because you've got recession. This is a periodontal health on a reduced periodontium in a successfully treated stable periodontitis patient. So if you look at this patient, their tissue looks pink and firm. They've lost some of the interdental papilla because they've had periodontal treatment in the past, and that's one of the side effects to periodontal treatment is you can lose your interdental papilla. They've also lost bone height, and so that's going to have that happen too. But if you probe around this patient, you're probably going to get all 2 and 3 millimeter pockets, no bleeding on probing, tissue is going to be pink and firm, fit snugly around the tooth, all of the things we talked about for health. And but if you look at the radiograph, you can see they've had significant radiographic bone loss. So they have had periodontitis. Now it's stable or holding steady. Gingival diseases and conditions. There are lots of gingival diseases and conditions, keeping in mind that gingival conditions fall under this same category. Gingival conditions are not necessarily caused by plaque biofilm. They can be other things that affect the gingiva. Characteristics common to all gingival diseases are signs of inflammation are confined to the gingiva. So if they have inflammation, it's confined to the gingiva. There's no attachment loss associated with the inflammation. So in other words, the junctional epithelium should still be attached just slightly above the CEJ. The bone levels should be 0 to 2 millimeters below the CEJ. They should not have any, it's initiated by plaque biofilm, and then inflammation reversible with plaque removal. So if they remove all their plaque, it's reversible and may progress to periodontitis if left untreated. So these are gingival diseases, not gingival conditions. So we have plaque-induced gingivitis, and we're going to have non-plaque-induced gingivitis. Plaque-induced gingivitis is a gingival disease. It's caused by plaque biofilm only. Plaque-induced gingivitis involves gingival inflammation in response to dental plaque. It triggers the immune system. The immune system sends inflammatory cells. The inflammatory cells cause edema and swelling as they try to fight the bacteria. If this disease can go on, this gingivitis can go on short-term or long-term, but it may not ever progress to periodontitis, but it can. You're going to see the changes in the color, the contour. You're going to have bleeding on probing. There's an increased gingival crevicular fluid, something you don't see, but that's happening inside the sulcus, and they may have some tenderness. So when you're probing, The base of the sulcus is ulcerated, and you might get some tenderness on probing. Signs of gingivitis. The papillary regions, or the interdental papilla, are involved first. They're the earliest signs seen in the area. So when you first start clinically seeing gingivitis, it's usually going to start in the papilla. It will then move to the gingival margin, so now it'll affect the papilla and the gingival margin, and then it will continue to become more diffuse. So it'll affect the papilla, the gingival margin, down the attached gingiva to the mucogingival junction. You can have acute or chronic. 3 categories of plaque-induced gingivitis. So we can have plaque-induced gingivitis on an intact periodontium, a reduced periodontium in a non-periodontitis patient, and gingivitis on a reduced periodontium in a successfully treated stable periodontitis patient. That category, number 3, is a very tricky one. We don't use it very often because typically what happens with your periodontal patients is that the inflammation doesn't just stay at the gingival margin. So gingivitis, remember, only affects the gingival tissues. So on a already periodontal patient, you have to kind of be able to differentiate if the pocket is just because the gingival margin is inflamed and causing a pseudopocket, or if they're actually losing clinical attachment. The majority of the time they're actually losing clinical attachment because that's the way periodontal disease works. Plaque-induced gingivitis on an intact periodontium. So if you look at this patient, you can see that the picture on the left, patient's got swollen papilla. They've got marginal redness. Those margins are rolled. You can see the redness. But if you look at the radiograph, their alveolar crest is intact and right where the bone height is right where it should be. That is gingivitis, plaque-induced gingivitis on an intact periodontium. This is what you're going to see on the bulk of your adult prophy patients. Then you've got plaque-induced gingivitis on a reduced periodontium in a non-periodontitis patient. So if you look at this patient, and you see they've lost some clinical attachment. They've got all this recession going on. This might be a patient who wore braces and they had some severely rotated, crowded lower incisors. The orthodontist moved these teeth. The bone is thinner in the front of the lower incisors, and so if you move the teeth a lot, sometimes you can cause recession. This patient now has plaque-induced gingivitis in the areas where they have recession, and you can see how red that is, and it's bleeding right there, but you can see all that redness. But if you look at the radiograph shows the alveolar bone is intact. It's about 0 to 2 millimeters below the CEJ. Gingivitis on a reduced periodontium in a successfully treated periodontal case. So successfully treated, they had to have had periodontal treatment and they had to have at some point become stable or stopped or completely arrested the disease for a period of time before they're considered a reduced periodontium. If you look at this patient right here, this patient had periodontitis in the past, and now they've got some gingivitis. You can see the marginal redness and the inflammation. This looks like a localized area right here because the rest of this looks pretty healthy still. So this is a localized area of gingivitis. How do we know the difference between gingivitis on a reduced periodontium and actual clinical attachment loss progressing? Is that gingivitis on a reduced periodontium is going to stay at the gingival margin. So you should not see any changes in the probing depth except for maybe 1 millimeter of change, and that is going to be a result of this pseudo pocket. You should not see several millimeters of change on a periodontitis patient and call it gingivitis. If you look at the radiograph, you can see they've had significant alveolar bone loss in that area. So they've clearly had some kind of periodontal treatment. They became a successfully treated periodontal case, meaning they had no clinical attachment loss over a period of time, and now they have gingivitis forming. Not the common, more common is it's going to be more clinical attachment loss. Then we have plaque-induced gingival disease with modifying factors. So you can have gingivitis with factors that are modifying it or making it, exacerbating it. So the potential modifying factors of plaque-induced gingivitis are found on page 105, and they include sex and steroid hormones, hyperglycemia, so blood sugar levels, leukemia, which is not very common, smoking, which is very common, and malnutrition, which again, you're not going to see a lot of malnutrition, not in our country. Potentially modifying factors of plaque-induced gingivitis. We're going to start with oral factors enhancing plaque biofilm accumulation. So things that are oral factors enhancing plaque biofilm accumulation include restorations, dental calculus, patient wearing a removable partial, orthodontic bands. Those are some of the examples of oral factors that enhance plaque biofilm accumulation. When a person has orthodontic bands, sometimes it's really hard to get all the plaque. Those of you who worn braces know it's really hard to get all the plaque off of the gingival margins. Hyposalivation is another one, reduced salivary or saliva production, xerostomia. I don't know if Professor Ramos mentioned that word, but xerostomia, it's a decreased salivary flow from conditions or medications. So oftentimes patients take blood pressure medicines, allergy medicines, antidepressants. All of those things cause their mouth to be more dry. And with dry mouth comes a reduced saliva production. Saliva plays a protective role in your mouth. It protects your teeth and your tissues. So a reduced amount of saliva allows plaque bacteria to breed faster. Fluctuations in sex hormones. We have puberty-associated gingivitis, the picture on the left. We have pregnancy-associated gingivitis. So gingivitis, as the hormone levels continue to increase during pregnancy, if plaque control isn't meticulous, the patient will develop gingivitis because it's more like an exaggerated inflammatory response to the amount of plaque. They can do the same oral hygiene procedures that they always did. Like maybe they've never flossed more than twice a week, and they've always been able to keep good, healthy gingival tissues flossing twice a week. Only now they're flossing twice a week, but they have gingivitis because their body during the pregnancy has an exaggerated response to the same amount of plaque. There's something called a pyogenic granuloma, which is seen during pregnancy. It's like a mushroom-like growth that happens between the teeth on the interdental papilla. It's an exaggerated response to plaque irritation. It grows it can grow pretty large. Not everybody gets them, of course, but you will see them in your pregnant patients occasionally. They do resolve after the pregnancy's over and the hormone levels go back down, but if they don't resolve, they can be easily removed. Hyperglycemia, diabetes, it's from poor diabetes or too much sugar in the blood. Leukemia is kind of a unique disease. It's not common for us to see patients with leukemia in practice, but you can. Smoking, very important. We're going to talk about smoking pretty extensively in another chapter. Not just smoking, but chewing tobacco, vaping, hookahs, all those things that people now do that bring nicotine into their body, and even just the smoke itself. And then malnutrition or lack of vitamin C can cause some problems. Gingivitis associated with diabetes is an inflammatory response of the gingiva to plaque aggravated by poorly controlled blood glucose levels. So sugar in the bloodstream, your body has an exaggerated inflammatory response to plaque. Reduction in gingival inflammation in diabetic adults may result in a reduction of insulin needed, and often seen in children with poorly controlled type 1 diabetes. So diabetes is huge. There's a huge link between diabetes, uncontrolled diabetes, and periodontitis. And so we always kind of, on a diabetic patient, you kind of look at it and you go, which came first? Is the diabetes causing the periodontitis or gingivitis? Or is the gingivitis periodontitis causing their blood sugar and their diabetes to not be controlled? Gingivitis associated with blood dyscrasias like leukemia, anemia, those are all considered blood dyscrasias. So you may see clinical signs of leukemia. You may see the clinical signs in their mouth before they know they have leukemia. However, this is what the tissue might look like, but I would not automatically jump to the conclusion if I saw a patient in my office like that they must have leukemia. There's usually what happens is they get this really horrendous case of gingivitis, and you treat it like you would gingivitis, and it doesn't go away. And you have the patient up their home care and it still doesn't go away. And you've tried every trick that you have in the book and the patient is doing their part at home and it's still getting worse, or at least not resolving. That's about the time when you might want to send that patient to have maybe some blood work done. I know in the perio office, we did that quite often. We know the patient's doing their part at home. We know we've done everything. We've pulled every trick out of the book we have, and they're still not getting better. So maybe there's some underlying condition. Maybe they have diabetes and they don't know it. Maybe they have some other medical condition like this leukemia and they don't know it. So from there, we might send them to their medical doctor to get some blood work done and see if anything shows up. Then we've got gingivitis associated with smoking. One of the major lifestyle risk factors for periodontal disease is smoking. However, with a smoker, you're going to have fewer clinical signs of the diabetes and gingival inflammation. I mean, with the smoking, you're going to have fewer clinical signs of the gingival inflammation. Their tissues don't get that spongy irritation the way that a patient who's a non-smoker might get. They have constriction of the blood vessels, so you don't have that same exaggerated response where you get all the bleeding on probing and all that kind of stuff. Their tissues tend to look more fibrotic. Groups most at risk and for malnutrition are infants, institutionalized elderly people, and then alcoholics. Institutionalized elderly are like nursing home patients, where they don't have good diets. There's a lot that changes when patients get closer to end of life. And then we've got vitamin C is the main culprit, but vitamin A helps to maintain healthy sulcular epithelium, and B complex helps to maintain healthy mucosal tissues. So we've got a bunch of different vitamins. Drug-influenced gingivitis. So plaque-induced gingival disease is modified by medications. We've got drug-influenced in gingivitis, which is an exaggerated inflammatory response to dental plaque and a systemic medication. So you'll notice that all of these modifiers, they're more of a inflammatory response to plaque. So the plaque is present, and then it's how your body responds to the plaque. But the plaque has to be present for your body to have that response. You've got Drug-induced gingival enlargement is an increase in the size of the gingiva resulting from systemic medications. Let me show you some examples of that. This is what gingival enlargement looks like. So there are three main categories of medications that cause this. Anticonvulsants, which are used to manage seizures. Calcium channel blockers is a cardiac medication for high blood pressure. And immunosuppressants are used to suppress the immune system. Usually they're used after a transplant, but there might be other reasons that they're using something to suppress the immune system. Some sort of reason they don't want the immune system to attack itself. A lot of autoimmune diseases like lupus and Sjogren's syndrome, they might use immunosuppressants because they're autoimmune diseases that attack it. Your body's attacking itself. And so sometimes they want to suppress that so that the body stops attacking itself. The most common one you're going to see here are calcium channel blockers. That's a category of blood pressure medications that's very commonly used. Not everybody who takes these medications gets this result. These are very exaggerated results. What you will more typically see is some thickening of the interdental papilla, generally throughout the dentition. It might be thicker in some places, but what it's creating when it becomes thicker like this is pseudopockets. In medications that are affecting gingivitis, remember gingivitis is just confined to the gingival tissue. So the junctional epithelium is still attached in the same place. So in other words, the base of the sulcus has not changed. All of your additional probing measurement occurs above the gingival margin, or as the gingival margin raises, I should say. Plaque-induced gingival disease is modified by medications. Their clinical appearance of drug-influenced gingival enlargement is it usually occurs within 3 months of taking the medication. So the patient comes in and you've updated your medical history and they tell you, I've got a new medication. And you go, what is it? And they tell you, and it's a calcium channel blocker, which you will know by the time you finish pharmacology and become a licensed hygienist. Right away, red flags should be going off in your head. Okay, I could see some gingival enlargement. So then you lay the patient back and you look in their mouth and yes, I see their interdental papilla are much bigger and I'm probing them and I'm getting 5s and 6s, not because they've developed periodontal disease, but because their gingival margin is higher than it used to be. But the base of the sulcus is still attached in the exact same place. Oftentimes what happens though is the patient comes in and you ask them for updates in their medical history and they say, I'm taking a new blood pressure medication, but I don't know what it is. So you go, okay, well, when you get home, call me back with the name of the medication. Okay, so you move on with your appointment and as soon as they open their mouth, you see this thickening of the tissue and right away you're thinking, by chance is that new blood pressure medicine a calcium channel blocker? If you ask the patient that, they're not going to know. They didn't even remember the name of the medication. But when they call you back with that medication, and as you're formulating your treatment plan for that patient that day, you're going to take that into consideration, that they're probably taking a calcium channel blocker, and now we've got this enlargement of the tissue. If the enlargement of the tissue becomes a problem, and the tissue gets to be too bulbous and too thick to where the patient can't do their good oral hygiene at home, we may have to have a consultation with the doctor about changing the medication, or there may have to be some other oral hygiene aids added to accommodate for that. So we're going to have to work around that. The pattern is irregular, but it usually begins in the papilla. So the first thing you're going to see is some thickening of the interdental papilla. The anterior is affected more than the posterior. The severity is related to the ability to remove plaque. So if the patient has some slight thickness, but they're a good flosser and they always use their water pick and their interdental aids all day, every day religiously, then they're probably not going to have a problem. But if they're not a flosser and now you've gotten thicker interdental papilla, it's probably going to lead to some problems. No attachment loss is the key here. It is still gingivitis. It is still localized to the gingival tissues. It does not change the base of the sulcus. It does not result in bone loss. It does not result in destruction of the periodontal fibers. It is strictly inflammation of the gingiva. So now we have non-plaque induced gingival lesions. These are gingival lesions that occur that have nothing to do with the accumulation of plaque. They are the smaller, if even hardly existent in our clinic group. When you see a patient and you see inflammation in the tissues and you see bulbous interdental papilla, and you see the tissues are red, there's edema present. Unless you see some reason to believe that it's a non-plaque induced, it's going to be plaque induced. So you're going to go with plaque induced unless you can prove otherwise. So these diseases are not resolved after plaque removal. So the patient can brush and floss and use a water pick and everything else, but it's not going to resolve it because it's not the cause. But the presence of plaque can make it worse. And it's often a painful condition. So the patient usually knows they have something going on. And I'm going to show you a few examples. Classification of non-plaque induced gingival diseases: genetic, a specific infection, inflammatory and immune conditions and lesions, reactive processes, neoplasms, endocrine, nutritional, and metabolic diseases, traumatic lesions, and gingival pigmentation. So let's look at some of those in more detail. This is genetic developmental origin. If you look at, again, these are exaggerated pictures. This is something called hereditary gingival fibromatosis. It's rare, it's benign, meaning it is not deadly, and slow progressive enlargement of attached gingiva. The appearance is similar to drug-induced gingival overgrowth, but it's more rare. So if you see something similar to this, first thing you're going to want to do is see what medications the patient is taking or has taken. If they're taking some medication that's going to cause gingival enlargement, it's probably gingival enlargement. Specific infections. So you can have bacterial infections like NUG, and NUG is a necrotizing gingivitis. You can have necrotizing periodontitis, which is basically like NUG that affects the deeper periodontal structures. Or you can have necrotizing stomatitis. They are severe inflammatory diseases caused by bacterial infection in patients with specific risk factors, including poor oral hygiene, stress, smoking, poor nutrition, or a compromised immune system. The times I have seen NUG, which is necrotizing ulcerative gingivitis, the U is ulcerative. The times I've seen that, it's usually somebody who's under a lot of stress. And I don't just mean like some stress, but a lot of stress. And when you get under stress, your hygiene goes bad. Because the last thing you want to do is stand there and floss your teeth when you've got your life falling apart and you're stressed. The clinical appearance, it has very distinct clinical appearance. You have your ulcerative and necrotic papilla. So you can see in this picture, the papilla are very big and inflamed. And the gingival margins. The gingival margins are extremely inflamed because you've lost your nice arches. You've lost that scalloped margin that usually appears because there's so much inflammation. And the papilla appear what they call punched out or cratered. So, so you look from tooth to tooth and it actually dips down some. It's kind of hard to see in this picture, but you can see how, like in this area right here, the tissue just is dipped in. It's not, the papilla aren't knife-like. So it's a classic sign of NUG. Other bacterial infections, they're uncommon. Specific bacterium is not commonly found in typical plaque biofilm. So these are the lists of some of the bacteria. Don't worry about memorizing those, but know that there are bacteria that are not found in typical biofilm, and they overwhelm your host resistance. So your body's response to them becomes exaggerated. Gingival lesions are painful ulcerations, shakers, mucus patches, or atypical gingival inflammation. And you can see right here how that's really ulcerated. Viral origin. So probably the most common one of viral origin is going to be herpes simplex, right here. HPV is another one, but the most common one is going to be herpes simplex. So primary herpetic gingivostomatitis is an initial oral infection with the herpes simplex 1 virus. The herpes simplex 1 virus has an initial onset. Redness and multiple vesicles appear, so blisters, that easily rupture to form painful ulcers. When patients have a primary herpetic outbreak, the outbreak is painful. Oftentimes they can't eat, they can't brush their teeth. It affects infants and young children, but may affect young adults. The statistics shows that generally most people are exposed to the herpes simplex virus when they're young. So somebody has a herpes lesion on their lip and they're over there sharing food or kissing on your baby or drinking out of the same drink as your young child, their young child, and they get infected by it. By the time the individuals reach middle age, about 70% have been infected by the HSV1, herpes simplex virus 1. In most cases, the virus never causes symptoms during this primary infection. So patients don't always have symptoms, but they can. This is what it looks like when they do. This is what a young child who was infected by the herpes simplex virus looks like. They have all these vesicles or ulcerations on their tongue and inside their mouth. This is another picture of fiery marginal gingiva. This is an extreme picture, but this one is a more common, typical thing you'll see. So stress brings on, once the virus is in your body, it lies dormant and it is usually triggered by trauma or stress. And so when I say trauma or stress, occasionally you will have a patient that has had scaling and root planing, and between the stress of the procedure and the trauma to the tissue and the mouth, they break out with some herpes lesions. Candidosis or mycosis are fungal origin. So fungal infections are commonly seen in patients that wear dentures or removable partials. They get a fungal or a yeast infection. Mycosis is like common in HIV patients. These are not as common. And when a patient wears a denture or a partial and they take out their denture, you will always have the patient take out their denture, even if they don't want to leave their denture out while they're at the appointment, because people are very self-conscious. Always have them take out their denture and check the tissue underneath, check the denture for fit, make sure it's fitting easily and tightly like it should. But the main thing you're looking for is yeast or fungal infection underneath that denture. Inflammatory and immune conditions, hypersensitivity reactions. So you can get contact allergies, plasma cell gingivitis, erythema multiforme, autoimmune diseases such as pemphigoid, lichen planus. Lichen planus is another one. You will see lichen planus a lot. And then lupus, granulomatosis, inflammatory conditions like Crohn's or sarcoidosis. Hypersensitivity reactions are common. People use toothpaste, mouth rinse, chewing gum. They use all kinds of spectrum of products now that are available in your toothpaste, your mouth rinses, and your chewing gums. So if a patient comes in with like this, which what appears to be an allergic reaction to something, fiery red, diffuse redness, ulcerations, start with the obvious things. Did you change toothpaste? Did you start a new mouthwash? Chewing gum? Any other kinds of products you're using in your mouth? Are you whitening your teeth? All those kinds of things. There's peroxides in the toothpaste for whitening. There's ingredients for tartar control. There's ingredients for sensitivity. There's flavoring agents. So there's all kinds of stuff they put in your toothpaste and your mouth rinses now. And so we have to kind of be aware of when patients make changes. Tissue sloughing. I don't know if any of you have experienced tissue sloughing, but the patient opens their mouth and you can literally wipe off. There's like stringy tissue that has sloughed off their attached gingiva usually. And tissue sloughing is commonly seen in patients that are having a reaction to either a toothpaste or a mouth rinse. It doesn't always hurt. Sometimes it does, sometimes it doesn't. Tissue sloughing doesn't usually hurt, and it doesn't result in any additional problem. It just is something that you're noticing their tissue is responding to the product they're using. Erythema multiforme is a disorder of the skin and mucous membranes. May be due to an allergic reaction or an infection. It's not that common that I'm aware of. And it can lead to ulcerations and like crusty lip here, corners of the mouth. Lichen planus you will see a lot. It affects the skin and mucous membranes. It can look a variety of different ways. Typical lichen planus appears like this. It's on the buccal mucosa. You can see it on the gingiva, the attached gingiva. You can see it on the retromolar pads. But it looks like this. It's characterized by these lacy white patches. And see how that spider web or lacy look? It can manifest itself in a more acute phase like this, where it becomes painful, red. Usually the patients, when they have this form, they can't eat. They can't brush their teeth. They get plaque accumulation, and then the plaque exacerbates what's already going on in their mouth. It's treated usually with steroids. So they'll use a topical steroid, not an over-the-counter one like you buy hydrocortisone cream, but there's a specific one that's made that helps it stick to mucous membranes, because if you try to put a cream on your gums, it's going to like wash off with your saliva right away, and you're going to just be eating it. So in this case, it's made to stick to your gingival tissues to help you heal. Reactive processes. So you can have epulis, which is fibrous tissue. This is the picture of the pyogenic granuloma we talked about. So this is actual tissue. It's not fluid filled. You can have pre-malignant changes, such as leukoplakia and erythroplakia. So leukoplakia is another one you will commonly see. Leukoplakia is a pre-cancerous state. Where you commonly see leukoplakia is patients that chew tobacco. So you will pull out their lower lip and you will see this tissue that's like white striated lines, and it looks irritated. It's kind of a generic name for a change in the tissue. It can lead to cancer because it's a pre-malignant state. That's the point where we want to do really, really effective discussions with patients to try and work with them on stopping their habit. Then we can have malignant ones, squamous cell carcinomas, leukemias, and lymphomas. You will probably at some point in your practice see a carcinoma in the mouth. And Endocrine, nutritional, and metabolic diseases like vitamin C deficiency. This is what this looks like. This is not common. I don't know if I've ever encountered this in my lifetime, but be aware that it can be a problem. Traumatic lesions. Traumatic lesions are big. So physical or mechanical traumatic lesions might be toothbrushing. So the patient is brushing their teeth and they hit a wrong spot. Chemical or toxic chemical ones, aspirin can cause some of that. Hydrogen peroxide can cause chemical burns. So a patient is wearing bleaching trays, it can cause some burning to the tissue. Some of your toothpaste agents can cause toxic burns. Another example, the self-harm. Other traumatic lesions that patients get that are really common are pizza burns or hot coffee or some kind of burn that food or drink that causes the tissue to die off and peel. And then you've got thermal insults. So that should be up in here. Sorry, you've got your burns of your mucosa. And then your gingival pigmentation. Gingival pigmentation, like you can have an amalgam tattoo. You can have smoker's melanosis. So when people smoke, their for years, their gum tissue actually like becomes pigmented or changes color. So these aren't quite as common as problems, but remember this entire category of non-plaque induced gingivitis, these are more rare things. You will see lichen planus in your lifetime, but oftentimes it's accompanied with a periodontitis. So it's kind of like the two feeding off of each other. So that concludes our discussion or our presentation on gingival diseases, health gingival diseases and conditions.